Good afternoon and good evening, everyone. I am Dr. Rahul Mandlik from Shalina Healthcare. A very warm welcome to all our audience today, and of course, our speakers who have agreed and been so kind coming forward and being part of this program today to help educate our healthcare professionals. Alongside with our educational partners like SOPOC from Ghana, NMA from Nigeria, and PPB, Kenya. This webinar is brought to you by Shalina Academy, a unique initiative by Shalina Healthcare, under which we are offering full range of digital as well as physical educational platforms for healthcare professionals across Africa. At Shalina Healthcare, we have been providing health solutions from last 40 years. And being a leader, we are able to provide this service by making high quality, affordable medicinal products which are manufactured in our own WHO approved facility. Additionally, we are also heavily involved in patient centric activities and services like disease screening camps, patient education camps, and we strongly believe and we are actively involved in medicinal product research. With that, let us start off in today's webinar, which is 20th webinar in this series, started under Shalina Academy. Today's speakers are going to interact upon one of the most common health element, that is cold, flu, and acute cough, and how to rationally use antibiotics in such respiratory issues. Let me quickly introduce Dr. Pradyut Waghray. Sir is a managing director at Kunal Institute of Medical Specialties Private Limited from Hyderabad, India. Dr. Waghray is a professor and HOD at SVS Medical College, Mahabubnagar, India, and also a senior consultant pulmonologist at Apollo Hospitals, Hyderabad. He is a honorary consultant pulmonologist to the Armed Forces in India, and Sir has recently conferred with the fellowship of the Academy of Medical Specialties by the Indian Medical Association. He is a fellow of the American College of Chest Physicians, a member of British Thoracic Society, and a gold member of European Respiratory Society. He has been recently elected as a fellow of the Royal College of Physicians, London, UK, and Sir has many publications and presentations to his credit. Welcome to you, sir.
Thank you.
We also have Dr. Alain. Sir is a senior specialist in family medicine at Polyclinic Department of Korlebu Teaching Hospital, Accra, Ghana. He is also acting head of Polyclinic Family Medicine Department at KBTH in Accra, and also training and research coordinator at the same department. Dr. Alain is also coordinator of National Asthma Guideline Development in Ghana and a part-time lecturer at Department of Dietetics in School of Biomedical and Allied Health Sciences in University of Ghana. He has got membership of West African College of Physicians in Family Medicine, and Dr. Alain has actively worked on association of psychological stress with asthma morbidity of men and women while working for the research for fellowship in family medicine. And Dr. Alain has got trained in primary right asthma care at International Primary Care Respiratory Group in Dubai. Welcome to you, sir.
Thank you very much.
So before we move ahead, I would like to have some couple of housekeeping rules here that there will be a chance for audience during the session that you can post your questions, and we will make our best efforts to have some time for the live interaction based on your questions. I would also like to inform you that this is for the first time we are providing this provision to you that you can get and download your certificate of participation right after the program. So to earn your certificate, which is signed by both the speakers, you can see on the screen, you need to hit on the quiz tab, which you can see just below the live window. So after hitting the quiz tab, you will be taken to the separate window. There is a small quiz based on today's learning. You can attend that and get your certificate. Thank you so much. I would like to hand over now session to Dr. Pradyut.
At the outset, I would like to thank so much for the organizers and Dr. Allen in particular. Last time we missed him. And welcome to you all. And I bring good wishes from India to you all. Stay healthy and be healthy. So we will talk today briefly about the cold, flu, and acute cough. It is the common things which we encounter in our day-to-day practice. And the biggest thing which we want to stress today is don't rush to antibiotics to treat these common conditions. If we see the common cold, which we all have in our life sometime or the other, the common cold is an acute. It is self-limiting viral infection of the upper respiratory tract. It's a simple viral infection of the upper respiratory tract, which involves the nose, the sinuses, the pharynx, and the larynx. Whereas when you compare this with flu, flu is due to a super contagious virus, that can make us feel really miserable. It can cause severe body aches, myalgias, headache, and also high fever. It is also called as influenza. The symptoms of flu are usually more serious when compared to the common cold. Common cold, you will have typical sneezes and stuffy nose, but unlike the common cold, in flu, you may have extreme body pains, fever, headache, etc. We must know that cough is basically a protective mechanism. It's a part of the body's way of responding when something irritates our throat or our airways. As we know, cough and cold are very common. Most people have it during the autumn or the winter, and it may range from 2 to 4 or 5 attacks in a year. It is seen more commonly in children. And we must realize that these are infections generally caused by viruses which do not require any antibiotics to be given. They respond to symptomatic treatment on over-the-counter available medicines. They are very rarely serious, and they usually get better by themselves unless the patient is immunocompromised or having some sort of low immunity like diabetes or some is on steroids or underlying cancers or HIV. Then only there is a high chance of getting serious. But by and large, they are very mild infections. But they can affect a patient's quality of life. And very rarely, as I told, sometimes they can go down into the chest and cause infections like pneumonia. So what they need basically is a symptomatic treatment. Then it is important to differentiate between the symptoms of cold and that of flu, because both common cold and flu may seem to be very similar at first, because they are both caused by viruses, and they affect the respiratory system, especially the upper respiratory tract. So their symptoms are very, very overlapping. There are subtle differences between the two. Cold symptoms are usually milder than flu, and they develop slowly over a span of time. And the flu can lead to complications like either sinus infection or ear infection or lung infection cause pneumonia. So if you see the symptomatology of cold versus flu, fever is usually higher in flu. Sometimes it is seen in cold. Headache is more common in flu when compared to simple common cold. Body pains, aches and pains are usually severe seen in the flu conditions, and very mild to very slightly in the common cold. With the flu, patient feels extremely weak, fatigued, and this weakness can last up to 2 to 3 weeks, which is not a feature of simple common cold. Whereas, if you see the stuffy nose and the sneezing and sore throat, these three complaints, stuffy nose, sneezing, and sore throat, are more common features of common cold. They are less seen in the flu. Chest discomfort and cough is common, and it can become severe in cases of flu, but it is usually mild to moderate with a hacking cough in a simple common cold. So if you see, the mostly the stuffy nose and the sneezing and the sore throat are common parts of common cold, whereas headache, high fever, body pains, weakness, lethargy, these are all the features of the flu. So this can be easily differentiated. And unless the patient is having immunocompromised condition, the complications are very rare with common cold. So we must realize that both these are all viral infections. So antibiotics will not help there. Antibiotics are drugs which help us in fighting bacterial infections, not viral infections. Okay, but most of the respiratory infections causing upper respiratory tract infections are caused by the viruses. So we know that antibiotics can't cure a virus, so why give the antibiotics? What we need is a just simple symptomatic treatment. The unnecessary use of antibiotics is leading to antibiotic resistance, which is a huge problem all over the world. And if we don't take action now, then we will not have any more new antibiotics left to treat real complicated bacterial infections. We have available many of the OTC, that is over the counter available medicines, herbal medicines. Herbal medicines are now, which are used so commonly, and they, in the last 10-15 years, we have seen a lot of uprising in the herbal medicines, because these medicines have found to be safe. They are not antibiotics, and they have practically absolutely no side effects at all. They have been used for ages by our grandmothers and before that. So what I recommend is herbal medicines should be the first line of treatment for simple common cold and coughs. And in fact, these are the guidelines recommended by the National Institute for Health and Care Excellence, that is NICE guidelines as well. We have different types of OTC medicines available, which we will be discussing in our course of discussions, and which are actually recommended for the symptomatic management of cold and cough. So herbal medicines now are offering a serious potential and excellent alternative for symptom relief of patients with cold and cough. We don't have to resort to higher antibiotics for that. So I thank so much for this introduction, and I will welcome to have an interactive session here. Thank you so much.
Thank you very much, Dr. Waghray. That's an excellent presentation. And as a primary care physician, I must say that this topic is very relevant. I'm not sure if I encounter any condition more often in my practice than these very ones we are talking about. But we would agree that in clinical practice, it's not so easy being very exact about what one is dealing with, whether you are dealing with common cold or flu. But I must say that your presentation has made it very clear, and the summary of what I get as the distinction between common cold and flu is that common cold will normally present with local symptoms. That is local respiratory tract symptoms, nasal symptoms, sore throat, and then stuffy nose. But common flu would, on the other hand, give us more of generalized symptoms, weakness, fever. So that makes it quite easy for us. But one other condition that is difficult to distinguish from these two is lower respiratory tract infection. So normally a patient presents you with these symptoms, and it's so difficult to tell whether we are dealing with an upper respiratory tract infection or a lower respiratory tract infection. So having given us an understanding of what common cold and flu look like, can you tell us how different these conditions are from lower respiratory tract infection, and how do we distinguish them in clinical practice?
See, the upper respiratory tract, if you see the anatomy, it extends from the nose or sinuses to the pharynx and to the larynx. So anything above the voice box or anything above the larynx is an upper respiratory tract infection. Anything below the larynx involving the airways and the lung parenchyma is the lower respiratory tract infections. Now, the predominant upper respiratory tract infections are due to viruses, as we have discussed just now. And the patients usually present with some amount of cold, cough, body pains, sore throat, stuffy nose, and some fever. and then they respond within a span of week to 10 days. Right, some symptomatic treatment like paracetamol, ibuprofen, some cough syrup with honey-based cough syrups are quite helpful in these patients, and then most of the herbal medicines available. Now, if your symptoms do not respond in a week or so, and then you must be cautious that it has gone to the lower respiratory tract, and then this cough becomes productive. The patient tends to bring out yellow or green color sputum. So there is increase in cough, there is purulence of the sputum with yellow or green sputum, and the temperature begins to rise. So these are the danger signals that the lower respiratory tract is getting involved. And also some people can have breathlessness, some people can have increased respiratory rate, and the fever refuses to go away. So that's the time to consult your physician, and probably he will need an antibiotic at that time.
So thank you very much for that response, because as a primary care physician, that helps me a lot to know when I can start empirical antibiotics, because sometimes one is not really sure. So I'm sure the audience appreciates it, and it will help us to decide when to avoid antibiotics and when to consider antibiotics. So as Dr. Pradyut said, if you do not have these features suggestive of lower respiratory tract infections, I think that we should be very conservative about starting antibiotics. So Dr. Pradyut, unfortunately for us, we are in difficult times, COVID times, and COVID is quite a complicated condition. Would you advise us on how how COVID comes into this whole picture? How we can distinguish? Because I would think that COVID looks on some occasions like upper respiratory tract infection. On some occasions, too, it may present as lower respiratory tract infection. So, what would be your recommendations on how we should approach? Picking out COVID from this set of conditions we are dealing with.
Yes, Dr. Allen, in the COVID pandemic, quite often we had this problem because it confuses whether it's a normal viral infection or is it COVID-19. See, there are certain points which you should be aware of. Most important is the history of contact. If a patient has come to us with history of some sore throat, upper respiratory and cough, it can be viral, it can be COVID. But if you have a history of contact with a COVID patient in the last 10 to 14 days, then your diagnosis of COVID becomes important. And you should try and rule it out by doing an RT-PCR test, especially in the pandemic. There are certain points which we should look for. Now, COVID, the viral multiplication phase occurs up to the 1 week. Okay. And so if the patient's cough is increasing, if the patient is developing fever, which is refusing to go away after day 5 of infection, then become cautious. If the patient is developing respiratory distress, like if he is getting breathlessness, if his oxygen saturation measured by pulse oximeter it's coming down slowly, dipping down less than 94 or 93, which are not seen in common cold. So these are the warning signs that this patient may have a COVID infection. So in summary, during COVID pandemic, if a patient comes to you with upper respiratory infections, keep COVID in mind, rule out with an RT-PCR, and because most cases may be of COVID itself, or if these are negative, then it becomes a simple viral infection. And then look for the signs of COVID, that is persistent cough, persistent temperature, refusing to go away, extreme weakness and lethargy, a patient getting extremely tired, he's getting breathless, increase in respiratory rate, and dip in oxygen saturation. These are the warning signs that you must seriously consider it to be a COVID infection.
Wow, those are very, very useful points. Thank you so much. Dr. Pradyut, again, cough is very common in these infections. And, sometimes it's very difficult to tell whether a particular presentation of cough gives you a suggestion as to the possible microbial cause. I think you touched on it briefly, but really, can you give us some guidance on characteristics of cough and how it can guide us and give us some idea of what microbial etiology we may be dealing with?
Yeah, see, as I told you, in viral infections predominantly, which is very commonly we see, patient will have a dry hacking cough because it involves predominantly upper respiratory tract, pharynx or larynx. It has a dry hacking cough, or it may have some mucoid sputum production, that is white color mucoid sputum production, which is not purulent. And this is usually associated with sore throat, upper respiratory tract symptoms, some nasal stuffiness, etc. That is typical of a viral cough. And it is important to know that even after the infection goes away, the cough lingers on for some time. That is due to the inflammation in the airways due to the infection. So don't think that the disease is getting worse. Now, secondly, if you are doubting a cough due to a bacterial infection, for example, the commonest cause of a community acquired pneumonia is being a streptococcus pneumonia or even Haemophilus influenzae, Moraxella catarrhalis. So any of these bacterial cough will have a typical productive cough. Patient will bring out lot of sputum, unlike the viral cough, which is predominantly a dry cough. Here he will have a purulent cough, which can be yellow or green sputum, depending on the organisms involved. For example, I can say if you have a Klebsiella pneumonia, you will get a typical, anchovy sauce pus or a red color, red tinged sputum. If it is a cough is due to pneumonia, you will get a rusty color sputum. So there are certain indications you get by the just by the nature of the cough and the color of the sputum. So that is how you differentiate between basically a viral and bacterial and the type of bacteria producing certain typical symptoms. In India, we see a lot of tuberculosis, and they have invariably cough, hacking cough. They bring out sometimes blood in the sputum as well. And then, if there is a history of contact with tuberculosis, if the X-ray shows any lesion, then you think of tuberculosis. So that is how you can differentiate various types of diseases based on the nature of the cough.
Wow, those are very, very useful points. Thank you so much, Dr. Pradyut. Again, would you say that bacterial, these symptoms of when respiratory tract infections are of bacterial causes, they don't have nasal symptoms at all? They don't have sneezing, nasal stuffiness, so that we can use that as a basis for distinguishing viral from bacterial causes. Would you say nasal symptoms are discriminant of the etiology?
Most of the infections, they initially start as a viral infection when they are confined to the upper respiratory tract, like nasal symptoms predominantly. And then if they do not progress to superadded bacterial infections, they stop at that level. Patient will have some stuffy nose, some sore throat, cold, fever, and then he improves in a week's time. But as I told, if the fever is persisting and if the patient is developing a productive cough, then it has entered the lower respiratory tract, and then probably he has a superadded bacterial infection. It is then that we have to start him on an antibiotic. Preferably, we give amoxicillin clavulanic acid antibiotics, which takes care of the commonly community-acquired infections affecting the lower respiratory tract. So yes, nasal symptoms predominantly indicate a viral infection. And then as it goes down, if the patient is getting a superadded bacterial infection, you will get productive cough, which can be yellow or green.
Thank you very much, Dr. Rahul. I can presume that antibiotics prescription for respiratory tract infection is probably one of the main reasons for inappropriate or irrational antibiotic prescribing. What do you think? Do you think antibiotic prescription for respiratory tract infection is a major contributor of irrational antibiotic prescription?
I think yes, Dr. Allen, you are absolutely right, because all over the world, including in my country as well, we have lot of misuse of antibiotics. I have seen people giving antibiotics. See, if at all antibiotics are indicated, they have to be given not more than 5 to 7 days, because it will respond by that time, unless the patient has certain severe complications of the pneumonia, for example. But what I see, most of the time we see the fever reduces, but the cough lingers on. And the patient will continue to receive antibiotics thinking that the cough is due to the active infection going on. As I told earlier, most of the times, limit your antibiotics. First of all, if it is pure viral, don't give antibiotics. If it is bacterial infection with a productive cough, give antibiotics. Preferably, as per the IDSA guidelines, amoxicillin flavinic acid is one of the safe and good antibiotics to use. If you give it for 5 to 7 days maximum, the infections will disappear. The cough can linger on because of the inflammation in the airways due to the infection, and this cough will take its time to go. Here, you can make use of the routine cough syrups containing herbal remedies like honey, and you can go for certain cough lozenges like licorice, glycyrrhiza, and they really help in soothing out the cough. You don't have to continue antibiotics for long. We have seen by giving too much of antibiotics or unnecessarily use of antibiotics, we are seeing lot of antibiotic resistance. And when real need comes for bacterial infections, then we don't have enough antibiotics to use, and we go for higher and higher generation of antibiotics. So I think this antibiotic misuse, I think it's a very, very common phenomenon seen in most of the countries.
Yeah, Dr. Pradyut, that's a very great point you've made, because I think that is a clinical condition some call post-infectious cough. So a patient initially has community-acquired pneumonia, is given antibiotic, and then after some time, he comes to you again telling you that he's still coughing. In fact, I had a patient like that yesterday. He had cough with brownish sputum production some 2 weeks ago, and a doctor gave antibiotics for community-acquired pneumonia. Then I saw her yesterday complaining of the same cough. This time it had changed. Not much sputum production, and even this time the sputum production is just a little bit whitish, but she's still coughing. In that situation, the correct diagnosis is post-infectious cough. And as Dr. Pradyut is saying, it is one of the main causes of irrational antibiotic prescription. A practitioner may think that the infection is still persisting and then give a different antibiotic, but that is not the approach. Post-infectious cough may linger on for a couple of weeks. It can persist for 6 to 8 weeks, and the treatment is not antibiotic. Give cough mixtures and other symptomatic medicines for symptomatic relief. So thank you so much for this great point. Dr. Rahul, in your presentation, you made us understand how debilitating the symptoms of flu can be. Antivirals, do they have a role in the management of these viral respiratory tract infections, especially when they are very debilitating? Is there any role at all for antivirals?
Antivirals have certain limited role. As I told you, most of the viral infections affecting upper respiratory tract are, they go by itself. They just need a symptomatic treatment to relieve the symptoms. The viral as itself doesn't need any specific medications. But if the patient has any underlying comorbidities, like diabetes or maybe chronic lung disease like COPDs, or chronic liver disease or heart disease, or he's on steroids or some other immunosuppressive condition, then we may need to give him certain antiviral, like we give here for fluvial, which commonly used, oseltamivir for viral infection, but not very, very commonly. Very, very rarely we use, unless those who are immunocompromised. Most of patients, they do not require any specific antivirals. Unless the patient is developing complications of viral infections, like he is developing breathlessness, cough is persisting, fever is persisting, and has entered the lower respiratory tract and shows signs of pneumonia, then you have to take the help of antivirals like oseltamivir. Otherwise, they are self-limiting diseases as far as the upper respiratory tract is concerned.
Thank you very much for this very useful answer. Dr. Pradyut, again, with regards to the symptomatic treatment of these upper respiratory tract infections, can you give us some guidance? How do we treat the nasal symptoms? And the fever also, what is the preference? There is a perception that when it comes to selecting medicines for the fever in these infections, some NSAIDs have some beneficial effects for the nasal symptoms. So some NSAIDs, for example, can help relieve the nasal symptoms. What would be your recommendation for these symptoms, the nasal congestion and the fever?
See, in Simple common colds, for example, if you have a nasal stuffiness, what you need is an anti-allergic and a decongestant. Like you will have either diphenhydramine, you have promethazine, you have phenylephrine combinations available. For example, promethazine is a good anti-allergic, phenylephrine is a good decongestant. So the stuffy nose symptom will be reduced. Then you can use saline sprays, the simple normal saline. That will help in relieving the nasal congestion. If you have a cough which is dry, hacking cough and troubling you then you can take the help of simple herbal cough syrup, which contains licorice, ginger extracts, or menthol, honey based containing cough syrups. These are all very, very effective. If you have a severe sore throat, for example, you can do some salt water gargles. Along with that, you have some lozenges available, again containing licorice, ginger, even turmeric. Turmeric, I remember our old grandmothers used to give us milk mixed with turmeric. Turmeric has a very huge response, and a very, very lovely ingredient, a phytochemical, when used in such upper respiratory infections. Then if you have a cough which is, the sputum is getting very thick, for example, you are unable to bring it out and it really is troubling you a lot, you can take the help of expectorants like guaifenesin or even bromhexine along with menthol. These are all the few combinations which are available, which are not serious medicines. They are not antibiotics. They are simple cough syrups, lozenges, which help you soothe your symptoms. So these can be made use of in stuffy nose, cold, sore throat, and body pains. Body pains, you have paracetamol and ibuprofen combination. Safe to use. Absolutely no side effects. Aspirin, unlike aspirin, which we cannot use in pediatric and adolescent age group because of the fear of race syndrome, the paracetamol and ibuprofen can be very safely used in these patients. So I think 99% of patients, they respond to this treatment. Very, very few patients may need antibiotics if they develop superadded bacterial infections.
Thank you very much for these very useful answers. Dr. Pradyut, you've talked about cough quite a lot, but I want us to look at cough as a symptom. There are so many cough preparations on the market. Cough suppressants, expectorants, and then lately, my favorite, the herbal-based cough preparations. As practitioners, can you give us some guidance on which cough preparation to select for which cough characteristics? When do we select the herbal-based cough mixtures? When do we opt for expectorants or cough suppressants?
Yeah, I think it's a very important question because we all get cough in our day-to-day practice. If my patient has a dry hacking cough, I will go for those syrups which are honey-based, which contains licorice, glycyrrhiza, ginger, which are very soothing, and they really cause cough suppression. They may have some amount of dextromethorphan in them in addition to this. And these honey-based cough syrups particularly, we find them very, very useful. Some of them, they also has a combination called shati, which is very, very effective in this dry cough. Then if patient having a productive cough, unable to bring out the phlegm, has thick viscid sputum, we have syrups available with guaifenesin, bromhexine, and menthol combination. They are really soothing to the throat and they help in bringing out the sputum as well. If he is having associated congestion of the nose, then you can use promethazine or diphenhydramine combination with ammonium chloride. That's another good syrups available. So we have variety of herbal cough syrups, lozenges, etc., which can be helpful in relieving the dry cough, and also expectorants like bromhexine and guaifenesin in thick viscid sputum.
Thank you very much. Yeah, a bit about herbal cough mixtures. I think that some of us are getting used to them. How effective are they, and how safe are they?
I find herbal cough syrups to be very, very safe, because if you see, the herbal cough syrups are all natural products. They are not synthetically made. They are available with us since generations, and we have been using it in our diet since a long, long time, many of these drugs. And now they are being properly formulated in a syrup form and given to us. So I think it is very safe to go for herbal cough syrups, herbal lozenges, and rather than go for the stronger cough syrups. See, some of these they may contain some decongestants, anti-allergics, which can cause little bit of sleepiness. So in the night time, so that can only like any other cough syrup. But otherwise, herbal cough syrups have practically no side effects at all. At least I didn't find anything in my clinical practice. I have been using herbal cough syrups with a combination what I have mentioned for almost more than 8, 9, 10 years now, and practically we didn't find any combination, any complications or any problems at all. Patient acceptance is also very good.
Yeah, thank you very much, Dr. Pradyut. Still on the antibiotics issue is quite dear to my heart, because I would wish that for all of us, both us and the audience, going away from this presentation or this discussion, would minimize our prescription of antibiotics for these conditions as much as possible, to only when they are really indicated. Prof, can you please give us some guidance? What strategies should we put in place in our facilities to guide antibiotics prescription in these situations? I think that one of the strategies that can help is to have facility-based policies on some of these recommendations. So, what should we do at our facilities to give some guidance on prescribing antibiotics for these conditions?
It's a very important question again, Dr. Allen. I think what we are talking about, going to talk about, is the antibiotic stewardship program. This is what we do. If we always should take a very good history. Where is the patient coming from? If he is coming from the community, and if he is a community-acquired pneumonia, you are doubting where he needs antibiotics because he has cough with productive sputum, then you must think what are the common community bacteria which he is having. He may have a Streptococcus pneumoniae, Moraxella catarrhalis, Haemophilus influenzae. Any of these can cause. So then you can give the ideal combination will be a combination of amoxicillin clavulanic acid given in the dose of about 500 milligrams twice daily or thrice daily, depending on his body weight, for a week, along with a macrolide like azithromycin or clarithromycin to take care of the atypical organisms. So a combination of amoxicillin clavulanic acid along with a macrolide is the ideal combination for a community-acquired infection. Number two, if your patient is admitted in your facility, if he's in the ward and he's getting low respiratory tract infection with fever and productive cough, then you may have to cover the gram-negative bacteria also. Then he may need either an injectable aminoglycoside or in the form of amikacin, or maybe a third-generation cephalosporin like piperacillin tazobactam. Third category is the patient who is in the intensive care unit. If it is the intensive care unit, usually some sort of immunosuppression will be there, and then he's with various gadgets are there, including ventilators or BiPAP machines or various lines. So he's prone to get staphylococcal infections as well. Here you have to cover gram-positive, gram-negative, and anti-staphylococcal antibodies as well. So it depends basically where your patient comes from. Since our outpatient practice, basically we get a community-acquired patients, our drug of choice will be amoxicillin clavulanic acid along with a macrolide combination.
Yeah. Thank you very much, Dr. Pradyut. During this COVID pandemic, we heard about the use of antibiotics for treating COVID. So that would suggest that antibiotics have some effects on treating viral infections. Is there any evidence at all that, I know this is an interesting question, is there any evidence at all that antibacterials have any role at all in curing viral infections?
You are right, Dr. Allen. We have seen right and left use or misuse of azithromycin and doxycycline being used in the COVID pandemic. Practically, we have zero evidence that these drugs really work. In fact, most of the COVID patients, apart from the Delta wave where they required remdesivir or other specific antivirals, most of the Omicron, what we have seen and recently, they just responded to simple symptomatic treatment, paracetamol, ibuprofen, some vitamin C, zinc, vitamin D, especially this vitamin C, zinc, they really helped a lot in these patients to overcome the disease, and hardly they require any antibiotics. So I think now the use of this azithromycin and doxycycline have practically found to be no role, though they have been used and misused right and left in the COVID pandemic without any evidence, I will say.
Great. Thank you very much. I have to go back to the nasal symptoms because, the nasal symptoms are quite distressing for our patients, and, giving them, treatment to relieve them is very important. One thing I struggle to understand is how H1 antihistamines play a role in nasal symptoms of viral cause. And is there really evidence that they work? Because, it's easy for me to understand that you give them for nasal symptoms of allergic origin. So, what is the mechanism behind, do they really work? And also, we have first generation and second generation H1 antihistamines. Is there a distinction between the two as to their effectiveness? Should we, would you say that the older generation are more effective than the second generation, the more recent generation?
It's a very interesting question. You see, a very important one as well. Because see, if you see the basic pathophysiology of allergies, what happens is once you get exposed to an allergen, it attaches to the mast cells, it causes mast cell degranulation, and histamine is released. The histamine is a very potent bronchoconstrictor. It's a very potent substance which can really manifest all the allergic responses, both in the upper respiratory as well as in the lower respiratory tract. So any drug which counters the effect of histamine is called an antihistamine. Okay, now our aim is to see that the histamine levels are reduced so that the allergic symptoms are reduced. So these are called as the antihistamines because they counter the effects of histamines. Now again, these antihistamines are divided, as you said, into the H1 receptor blockers and the H2 receptor blockers. The H1 receptor blockers are predominantly used in treating allergies, unlike the H2 receptor blockers, which are used in the gastrointestinal symptoms predominantly. So let us now not talk about the H2 receptor. We'll stick with the H1 receptor. Again, the H1 receptor blockers, or H1 blockers as they are called, they are again into first generation and second generation. The first generation H1 blockers are like, for example, the chlorpheniramine maleate, diphenhydramine. They are effective anti-allergic drugs, but the problem with that is they cross the blood-brain barrier. So that's why they may cause drowsiness. They may affect with the day-to-day work. So we give them at the bedtime so that the patient will have a nice sleep. But otherwise, they're very effective anti-allergic drugs. And but the only drawback is the drowsiness. Second, the other hand, we have the second generation H1 receptor blockers. Second generation is like loratadine, fexofenadine, and claritidine. These are the two things. Fexofenadine is very commonly available. Desloratadine. These are all the second generation H1 receptor blockers. They are effective. Though they are not as effective as the H1 receptor blockers in relieving the allergies, but the advantage is that they don't cause the drowsiness. And now we have the recently Bilastine available. These are found to be very effective without the drowsiness of H1 receptor. So basically, for example, if a skin urticaria comes, severe urticaria is there, needs immediate relief, then we need to take the help of the H1, like chlorpheniramine maleate, for giving immediate relief. But if it is not an acute allergic reaction where patient can wait for a couple of days to get a slower reaction, I will go for the fexofenadine or bilastine combination. So these are how you differentiate among the antihistamines H1, H2. H1 has first generation and second generation H1 receptor blockers.
Thank you very much. Let's talk about prevention. Because of COVID, we've all gotten used to social distancing and then wearing of face masks. With regards to these upper respiratory tract infections, is there a role for wearing of face masks? So, for example, if a patient comes with a flu or common cold, would you recommend that in order to prevent his or his family members from getting the infections, he should wear the face mask? And would you say that the family members should wear face masks in order to prevent the transmission of these infections?
See, before the onset of the COVID pandemic, we used to see that if one family member gets flu, everybody will get some common cold, flu, or otherwise, and we used to take it for granted. But now, with the pandemic, we have learned the importance of a simple thing called face mask, because it should be properly worn. I have seen people in India at least wearing masks hanging down only till here, and only for the show it is here. So it has no purpose. But if you wear it properly, covering the nose and the mouth, then obviously it is. See, all these virus infections are spread how? They are spread by nasal secretions, coughing, even talking, shouting, laughing. Any of these can shed these infected secretions. So I think wearing a face mask is definitely going to protect us. And we have learned this from the COVID pandemic. So much so, not only viral infections, we have hardly seen any tuberculosis patients in this pandemic because they are all wearing a mask, they are not infecting. Not only that, many allergies, asthmatics have not come to us with acute attacks because they are not getting exposed to any dust or pollution because they're wearing a face mask. So I think, yes, we have learned a very, very good lesson during the pandemic that to prevent any viral infection, simple thing is hand washing and wearing a face mask. So I think whether the COVID pandemic is there or not or going, face mask should be worn if you have any upper respiratory infection to prevent others in the family from getting affected.
Thank you very much. How about vaccinations? Are there any vaccinations available for preventing flu or even common cold?
Yes, in fact,
Are they
now,
recommended? And
yeah.
when are they recommended to? Are there any groups of people that these are particularly recommended for?
See, the vaccinations, number one, flu vaccination. Again, the acceptance of vaccination has tremendously increased after the COVID pandemic has come. People have realized the importance of vaccination and in preventing the common viral infections. Flu vaccine has to be taken once a year, especially at the beginning when the flu season starts. And that has to be repeated every year. That will not that will 100% prevent us from going into complications of flu. Even after taking vaccination, you may have some upper respiratory cold or cough, but definitely you will not go into complications. So number one is flu vaccination. Number two is pneumococcal vaccination. Whether it is a polysaccharide vaccine or a conjugate vaccine, you have to take the pneumococcal vaccination. Now the recent guidelines have come. Number three is the Tdap, that is tetanus, diphtheria, and pertussis vaccine, especially those who have chronic lung conditions like COPD, for example. Number four, shingles vaccine. And number five, COVID vaccine. These are the five vaccines recommended for people, especially with chronic lung disease, chronic heart disease, or any other comorbidities, because they will prevent infections to a longer way. As far as the respiratory system is concerned, the common vaccines are two which we are using: flu vaccine and the pneumococcal vaccine.
Thank you very much, Dr. Pradyut. I believe we've had a very wonderful discussion, and I have learned so much from you, and I'm sure our audience have. We are really privileged, I must say, to have such a distinguished professor to give us this talk. But before we end, let me give you a few seconds to just probably give us a summary or some important information. Going to go home with.
I think my take-home message will be that if you are diagnosing a viral infection clinically, or a common cold clinically, or even a flu, if he has stuffy nose, sore throat, cold, cough, don't go for antibiotics. Don't rush for the antibiotics. You will be creating more problems. Okay, the antibiotic itself may cause diarrhea, he may get weak, he may get dehydrated. Simply over-the-counter herbal remedies, cough syrups containing honey-based cough syrups, warm hot soups, lemon water. You can take care of lozenges, which are available again. Herbal-based lozenges are available. and these will take care of the diseases. Unless your fever or symptoms are persisting more than 1 week, then you think that yes, this is developing into superadded bacterial infection, and you go for the antibiotics. Again, you go for simple amoxicillin clavulanic acid. For fever, body pains, paracetamol, ibuprofen combination is more than enough. For nasal decongestant, diphenhydramine, anti-allergics like promethazine, phenylephrine decongestant, these are enough to make you feel better. Then I will tell about the vaccination. Not only the COVID vaccination, I think most of the preventable diseases by vaccination we must all take, like flu vaccination, pneumococcal vaccination, as I told you, the tetanus, diphtheria, and pertussis vaccination, and of course the COVID vaccination, which everybody is taking now. And then use the mask in a proper way to prevent not only COVID but also other viral infections. And please start believing in herbal remedies. I will give an example. We did some work on curcumin, which is a very commonly used drug all over the world. I think I'm sure in India also we use a lot of curcumin in the diet, and they have components not only against COVID. We have done some work on curcumin and COVID. We have found excellent results. Curcumin acts at not only preventing the COVID virus, it helps in preventing the multiplication of the virus. It helps in preventing the cytokine storm, which is generated by the COVID virus. So this is really a wonderful drug, and a lot of work is being done all over the world on curcumin. And I heard a lot of work is being done in your country as well on the herbal component. So I think be confident and be more sure that you are taking a good medicine, and go for the herbal medicines for your simple treatment. Only when you are getting complications or indicating of bacterial infection, then you go for the antibiotics. Otherwise, most of them are happy with these medicines. That will be my take-home message.
Thank you very much, Dr. Pradyut. We've had a very rich discussion, and my little addition will be about managing patients' expectations. No, I read a systematic review that looked into why doctors would prescribe antibiotics inappropriately for respiratory tract infections. And one of the main causes, or the main reasons, was patients' expectations. Patients would come insisting that you give them antibiotics when, in your judgment as an expert or as a practitioner, you know that antibiotic is not indicated. So in such circumstances, we should let our expertise rule rather than the patient's expectations. We should educate our patients and manage their expectations appropriately, and let them have confidence in the remedies that we have discussed, that they do indeed work, and one doesn't need antibiotic to resolve the symptoms of these infections when they are indeed not of bacterial etiology. So going away from here, we've armed ourselves with, very good guidance on how to approach these conditions. And also, we should all determine to be good stewards of antibiotics. They are the tools we have. If we abuse them and the current rage of antibiotic resistance continues, a time will come that we'll not really have any weapons to fight bacterial infections with. So especially in our part of the world, we should all be guardians or stewards of antibiotics, and let's stick to prescribing them appropriately and resist the temptations to prescribe them irrationally. So thank you very much, Professor, and thanks to all our audience. And once again, thanks to our organizers for the privilege of having us part of this discussion. Thank you so much.
Thank you.
Thank you so much, Dr. Pradyut, Dr. Alain, for this, I must say, very impactful interaction. As Dr. Alain has mentioned, I have personally learned a lot, and I'm sure our audience would appreciate this interaction. This is such a common problem. I mean, day-to-day seen issue in healthcare practice, whether it is a pharmacist practice, doctor's practice. It is commonly seen issue across the world, not just in Africa. And the way the interaction flow has uh, gone through. I really appreciate that, and very impactful messages. Thanks, Dr. Pradyut, for shedding some light upon the role and the importance of herbals in the management, in the symptomatic management of cold, flu, and acute cough symptoms. And it feels like that herbals are going to make their way for sure in the mainstream practice uh, than the sideline uh, management options. And Dr. Allen, I really appreciate, and I feel that your point which you have put forward is really important, that being a practitioner, doctors of pharmacy should take judgment based on their experience as a rule, and not as an expectation of the patient as a rule. So very key points and very key guiding tips for the practitioners today attending this webinar. Now please allow me, doctors, to take up some questions on behalf of our audience. I request both of you to respond to the questions. Uh, I was screening through the questions while listening to you. It was very tempting actually. So I have tried to screen some questions which you have not covered during the interaction. But pardon me if there is any repetition. So how can we differentiate between the cough due to bacterial or virus origin?
The viral cough, usually if it's affecting the upper respiratory tract, usually a dry cough with or without mucoid sputum, that is white color sputum, which is white and just like a water. So dry cough, dry hacking cough with or without mucoid sputum associated with upper respiratory symptoms like stuffy nose, cold, sore throat. That is typical of a viral picture. If the same virus is affecting the lower respiratory tract, then in addition to these, patient can have breathlessness, patient can have increase in his respiratory rate. That is regarding the virus. Now, regarding the bacterial infection, for example, the bacteria, if they're affecting the sinuses or if the bacteria is causing the ear, then they can have a productive cough where the patient can bring yellow or green sputum, indicates a bacterial infection. Same thing if it's affecting the lung, for example, pneumonia, patient can have high fever with productive cough, green, yellow sputum associated with breathlessness and increased respiratory rate. So that is how basically you differentiate between a pure viral and a superadded bacterial infection.
And I think that, as we also said, we should be able to distinguish cough that follows after a bacterial infection, which does not necessarily mean persistence of the bacterial infection, but a result of the inflammatory process. And that is what we will typically, as we said, call post-infectious cough. So post-infectious cough would follow after a bacterial pneumonia. But in that situation, the original symptoms may have changed. The severity of the symptoms may have changed. The characteristics of the sputum would have changed from brown, purulent sputum to thinner sputum, or the cough may even have become unproductive. In that situation, it is not the infection that is persisting. It is the inflammatory process which is prolonging the cough, and it may last as long as 2 months. Don't rush for antibiotics. Do not change the antibiotics, because it does not mean that the antibiotics you gave did not work. It is just the inflammatory process. So go for the symptomatic treatment. Cough mixtures. Thank you.
Thank you so much. Next question is again related to cough. How to manage cough-related issues in quite younger patients, maybe below 6 months old children?
Pediatrics, Dr. Allen, would you like to take that question? I treat basically the adults.
So I treat adults mostly, but I think that there are also, it's quite similar. Pediatrics, in the pediatrics population, I think viral causes are even quite prominent. I used to run a pediatric clinic before COVID. COVID came to end that clinic. But most of the time, the cases I saw were respiratory tract infections, and mostly the treatment is not very different from adults. We treat them symptomatically. So pediatric population also have specific cough mixtures for that age group. So they also do very well on pediatric cough mixtures, and there are also herbal-based cough mixtures for that age group. So for the cough, we'll go for those. And I think that with regards to the antihistamines, there are some that the pediatricians recommend for the very younger age group. For example, the less than 2-year-olds. There are some antihistamines that are preferred for that group. In the past, the second generation H1 antihistamines were not quite recommended for the pediatric, the less than 2-year-olds, but I think now the contraindication is less strict. But for that, the younger age group, less than 2 years, the preference is for the first generation antihistamines, especially chlorpheniramine. So if you need to stop the nasal congestion, those are options. Yeah.
I would like to add one more point here. In pediatric cases, especially if the child is coughing after exercise, or if the child is coughing and waking up in the night or early hours of morning with cough, please keep cough variant asthma in mind. Because most of the time we have seen children being pumped in with antibiotics, no response, where it's actually they needed simple bronchodilators and inhalers. So that is one thing we have to keep in mind, cough variant asthma, especially in the pediatric population. If he's a preschool child, he will cough while he is running in the school. That's why he stops playing in the intervals. If he's a small child, he will wake up in the night with cough. So that is one clue you get.
Thank you, sir. Very useful point. And how about these lozenges, like herbal lozenges are there? Can they be used safely in pediatric or in elderly population for sore throat or cough-related issues?
Elderly, I think, yes, they can be safely used. Pediatric, slightly we have to be careful because they may choke on it. That's one issue practically, because they choke it, then we are in soup. So otherwise, as far as the composition is concerned, they are found to be very safe. But for the fear of choking, we prefer the syrup forms in pediatrics rather than the lozenges. Adults, yes, 100% they can use. They are all these herbal lozenges. They contain turmeric, licorice, honey. They can be used very freely and safely as well. And they really cause good, smooth, effect on the throat.
And how about, sir, in some old children, like above 6, maybe?
Yeah, those children who are more than 6 years, who are aware of what they are taking, because by that time they take the solid foods, everything, they are taking normal diet. So they can be used, but not in very small children.
Good.
Above 6 years, 100%.
Yeah.
And,
I agree with you perfectly, Dr. Pradyut.
Fine. Let us move on to the next question. Can a patient get secondary respiratory bacterial infection due to flu and cold? I think Dr. Pradyut has mentioned it during the discussion. Yeah.
The clue you get is the patient has flu, and if he's getting productive cough, then you think that he's getting a superadded bacterial infection and try to treat with amoxicillin clavinic acid antibiotic.
Fine. So I think since we have many questions, please allow me to move on to the next one. The next question is, how do you treat a patient with history of chest pain for 5 days? Chest X-ray shows some opacities. Do you go straight to antibiotics?
Well, if your patient has chest pain, I will like to elaborate more on the pain. Is the pain increasing on deep breathing, which tells me that it is a pleuritic pain? Then I know that there is infection in the chest affecting the pleura and causing pleural inflammation, thereby causing the pain. Then yes, I will go for the antibiotic. But if there is a lesion in the lung, if it is a dull, boring, continuous pain, then I will keep malignancies also in mind. So it depends on the detailed history. How is the pain? Is the pain radiating? Is it related to breathing? Is the patient having cough, associated fever? That will help us in making a diagnosis whether it is infective lesion or a non-infective lesion in the chest. It's not alone the shadows as such. Overall history, physical examination, And then if he's getting sputum, I will go for a sputum examination to confirm whether it's a bacterial infection or tuberculosis or what it is.
Yeah. So, I mean, we have to keep in mind that pneumonia is an acute infection. There is no such a thing as a chronic pneumonia. So if a patient has had these symptoms for so long, you should look for other possible diagnosis other than pneumonia. So in this case of very long history, I wouldn't pneumonia wouldn't be my first consideration. So as Dr. Pradyut said, you may look for other possible causes.
Okay. Right. And next question is, it looks quite tricky, like flu is a symptom or syndrome. This is the first question. And the second question, which are the upper respiratory situations where you would recommend antibiotics?
Well, coming to answer the first question, flu is not, it's caused by influenza, but it is something like a syndrome. What you put is right, because flu can affect the upper respiratory, it can affect the lower respiratory and go into complications. People can die with flu if they have associated complication like ARDS or respiratory failure, especially as I said, if they are immunocompromised. So yes, I will call flu a syndrome because it can affect various parts of the upper and the lower respiratory tract. Secondly, your second part of the question was which upper respiratory infections you give antibiotics. Am I right?
Yeah.
So if the bacteria are affecting the upper respiratory tract, like sinusitis, otitis media, a dental abscess, these are the upper respiratory tract, upper area of the face which can get affected. Then I will go with the history again. If my patient has come with severe pain in the sinuses, high fever, if he is coughing out purulent sputum, or if he has an ear pain with sputum, if he has a dental pain with sputum, then yes, I will go for the antibiotics. And again, as I said, as per the IDSA guidelines, amoxicillin clavulanic acid, if used appropriately in the right doses for the right duration of time for at least a week, not more or not less, then it really gives a good relief. And if the patient is coming from the community getting upper respiratory infection, I will also like to add a macrolide to take care of the atypical bacteria. So that's how I will decide about the antibiotics.
Yes, so I would also add sore throat. So that is also another upper respiratory tract infection that you may need antibiotics. We know the potential cardiac complications. So it's not every case of sore throat that is caused by a bacterium. So we need to be able to distinguish sore throats that may be of bacterial etiology. So if a patient has sore throat and associated nasal congestion, nasal symptoms, you may think of, you examine the patient, do appropriate laboratory investigations. You should be able to distinguish between sore throat that is of viral etiology and bacterial etiology. If you pick up, you have a reason to suspect that the sore throat is of bacterial etiology, then you definitely have to institute antibiotic treatment to prevent, to cure it, of course, and also to prevent the other complications. Thank you.
Thank you so much. How about corticosteroids, doctors? Do you recommend them for the treatment of cough?
If the cough is due to, for example, as I told you, an allergic airway disease, I will recommend inhaled corticosteroids rather than oral corticosteroids. For the reasons, because inhaled corticosteroids are available in micrograms, unlike the oral which are in milligrams. Number two, inhalers are directly going at the site of action. For example, if the cough is due to asthma or allergies in the lung, if I give an inhaled corticosteroid, it directly goes in the site, has anti-inflammatory action, and reduces the cough. So I'll rather avoid the oral corticosteroids unless there's a condition of interstitial lung disease where the patient has dry cough, where the interstitium is involved, then they need oral corticosteroids as well. But otherwise, these are the only indications I will give for steroids individually as such. Sometimes you have to give for severe allergies. You may have to take the help of steroids for a few days, but then don't give it for a longer time.
And as Professor said, Cough variant asthma is it's a condition that is quite often missed. So we've learned about how to distinguish it from other causes. It tends to be nocturnal in nature and may have clear triggers. So cough variant asthma is another indication for inhaled corticosteroids. Thank you.
Thank you so much. Now, next question is related to adenoids, which is commonly seen again in pediatric population, whether it is younger child or older child. And the question is related to the allergic component, but both the speakers can shed light upon that, whether adenoids are only because of allergic component or there is also infective element in that. For Dr. Pradyut, information in Sub-Sahara Africa, in most of the countries, there is one environmental phenomena, that is harmattan, is the condition when lot of dust cloud or dust comes from the north part of the Africa to the countries in the Sub-Saharan Africa, and the question asked in this context that adenoids seen in this age group of pediatric patients is because of that, or there is also any infective side of that?
I feel that adenoids in a pediatric age group maybe because of the allergic component as per the climatic conditions in Africa. But I feel that there is a significant amount of inflammation going on. So probably I will put the child on antibiotics at this stage, because I know the adenoids can lead to complications, and most of the patients, they have snoring, and they have other, they can develop into super added bacterial infection. So my choice will be to go for antibiotics in case of adenoids which are symptomatic. Dr. Allen maybe can elaborate more.
And we should also be mindful that when adenoids are causing significant symptoms, we need to refer to the ENT specialist. Just giving inhaled corticosteroids or antibiotics may not be adequate, so we should remember to refer them appropriately to ENT specialists. And with regards to the harmattan, I think it's quite a challenging season for especially patients with asthma. The dust is one of the commonest triggers of asthma. So during those times, we should advise our patients with asthma to adhere to their inhaled corticosteroid prescription. And it tends to trigger a lot of irritant nasal symptoms. Nasal symptoms can be either irritant in nature or irritative in nature or allergic in nature. So sometimes patients come with irritative nasal symptoms, and when it is of short duration, you can give them the nasal decongestants or even the H1 antihistamines. When they are of prolonged, some patients already have allergic rhinitis, and during the harmattan seasons, they tend to have more troublesome symptoms. So they may need to be on intranasal corticosteroids. So the patients who would have very short duration symptoms, nasal decongestants are okay, and antihistamines are also okay. But those who already have allergic rhinitis that are exacerbated during the harmattan season, you may need to put them on intranasal corticosteroids. Thank you.
Thank you so much, sir. And in the interest of time now, I think we have very few minutes left now. I will go for last question. There is a patient, there is a 13 years old girl patient who is coughing mainly in night time and wakes up because of that. What could be the probable diagnosis for this?
As I told you, nocturnal cough, especially in pediatric patients, they wake up at usually between 2 to 4 a.m. That is the classical how they present with nocturnal waking of bronchial asthma. So I will look for other allergic features in her. I will ask for any skin allergies. I will ask for any upper airway allergies in the form of allergic rhinitis, which will confirm my diagnosis. I will also ask about any family history of asthma or atopy, because most of them, they have a strong family history of allergies of family. And if all of these are present, then I will go for a spirometry. If it is there available, I do a spirometry or at least a peak flow meter. to check for any diurnal variability, as that will confirm my diagnosis of asthma, and then I will start her on the inhaled corticosteroid. Because the we commonly see this, that most of the asthmatic patients are put only on the levosalbutamol because that relieves their symptoms. But we must realize that the basic pathology in these patients is inflammation. So inhaled corticosteroid, as per the GINA guidelines recently also, inhaled corticosteroids are the sheet anchor of treatment which have to be started early on. So yes, in this girl child, I will first possibility keep it as a bronchial asthma and then initiate the treatment.
Yes, so and then, I mean, even though the question is specific to a child, adults may have similar symptoms. Nocturnal cough, and it's very similar. It tends to be more commonly due to asthma, but we should also be mindful of gastroesophageal reflux disease, which tends to be worse at night. So it all boils down to the history. If you take a good history, you're able to narrow down on the history on the likely cause. But the commonest causes of cough, especially nocturnal cough in adults with normal chest X-ray, are three conditions: cough variant asthma, gastroesophageal reflux disease, and also possibly post-nasal drip syndrome. So if you rule out cough variant asthma, the approach is to treat the most likely cause. So if you think that is cough variant asthma, you do your inhaled corticosteroids, and if you are not happy with the results, you can look at the next more likely. If the patient has associated heartburns, you may think of the cough being due to gastroesophageal reflux disease, and then treat appropriately. If the patient also has symptoms suggestive of recurrent rhinitis, you look into the throat. Sometimes you may see features of post-nasal drip, and you can also, in that case, you should treat for post-nasal drip syndrome. So these are very common causes of long-standing cough with normal chest X-ray in adults. Thank you.
Fantastic. Thank you so much, Dr. Alain, Dr. Pradyut, for responding to most of the questions. And to our audience, that it looks like that some of the audience have joined late, and the questions asked by you audience, they are already covered in the interaction. You can access to the recorded webinar by using the same link, and we'll also send you the recorded webinars link, which you can go through. Most of the questions asked by you are already covered in the interaction by both the speakers, and I would like to convey our sincere thanks to both the speakers for this wonderful and very enlightening discussion on this subject matter. And also I would like to pass our big thanks to the audience who is showing great interest in our webinar series. So audience, you can even revert back with your feedback, with your suggestion, even topic suggestions for that matter, so that will guide us to line up our next webinars in the pipeline. So please stay tuned to our invitation flyers for the future webinar. And as I already mentioned that we are going to send you through email the recorded link and the snippet of this webinar. Thank you once again.
Thank you.
Thank you very much.
Thank you so much.